of the Therapeutics Committee meeting to order for February 7th, 2025. Consistent with past actions of the Therapeutics Committee, we'll take Optum's recommendations as a consent calendar. And our first step would be to invite items that the committee members would like to extract from the consent calendar for further discussion or revision.
This is Zach. I would like to extract the agents for the treatment of opioid use disorder or overdose.
Okay. All right, so that would be item I on the agenda. Are there any other classes that members of the committee would like to extract from the consent calendar? Okay. All right. So before the committee, we have the recommendations of Optum regarding therapeutic classes for re-review, with the exception of item I, agents for the treatment of opioid use disorder or overdose. Hearing no further discussion, we'll go ahead and do a roll call.
Okay, Dr. Shaw.
Aye.
Dr. Krupp.
Aye.
Dr. Marshall.
Aye.
Mr. Musial.
Aye.
Dr. Negendank.
Aye.
Dr. Patel.
Aye.
And Dr. Weber.
Aye.
All right, we have all ayes, so that motion will carry.
Okay, thank you. Dr. Weber, since you extracted the item regarding agents for the treatment of opioid use disorder or overdose.
Yes, thank you. So first off, I want to thank the public testimony and the commentary and the conversation that we had during the first session related to this particular class and the different agents that we have. I think it's always helpful for us as committee members to, just continue to hear different perspectives and to gather different opinions and different information about obviously what is an extremely important class of medication. So again, I appreciate the conversation that we had during the first session and during the second session related to this. And so I know that, as a committee, we want to make sure that we're looking at the treatment of this condition holistically. And I know one thing that was mentioned in that commentary was about thinking, availability and access to medications and how that might impact potential costs down the road in terms of admission to emergency departments or subsequent hospitalizations. And so I know that Optum has done quite a bit of work in this area of looking perhaps a little bit more broadly at kind of the overall pharmacoeconomic or just economic impact of these medications. And so I just wanted to kind of ask them to provide some comments on the work that they've done in this space. So Amanda and colleagues, if you don't mind.
Surely. So as you mentioned, we did do a lot of extensive analysis and kind of analyzing things in several different ways and how we could, make some of this work or think of the efficacy of the injectables versus the orals. And so we did reach out to the manufacturers asking for kind of data around oral versus injectable use and if they had any medical data around that and the basically overall outcomes of the injectables, right? And what that looked like. We did have discussions with one manufacturer around the data, but unfortunately found that data to be kind of lacking in that some of the oral dosing ranges weren't really utilized appropriately. And even despite that, it was really kind of a modest improvement. So we did have a call out to the manufacturers that this is really the data we need to demonstrate the ability to reimburse in a sense without PA or those things versus the oral, showing that there is a substantial cost savings, whether that's on the medical side or the overall outcomes, because as it is right now, it's just not there in the way that the state is looking. And so we've really asked them to if they're doing studies in that, or to consider studies in that, so that we can have that data and be able to evaluate that data. And unfortunately, the data is just not super compelling today or there, but we would like it to be, and we would like it to be there. So I think, at least from what I hear from the committee, and definitely from us at Optum in the state, like, we want to have parity, we want to have these agents, but we also need to have some level of financial parity as well. And so that also is not there, unfortunately. And so it just puts us in a really hard position from our space and our recommendations. And like I said, we put a lot of effort behind analyzing the data, analyzing the available data and the studies, analyzing the financial data, and analyzing the shifts, and really trying to think what we could do, as well as the outcomes data, to try and make, what we think is the best decision with the state, obviously, and had discussions even before we came to you, had discussions, and subsequently with the state, then subsequently with you. So we've had a lot of discussions, and that's kind of where we end up in how things are and why we presented the way we did. And obviously you all saw during the second session kind of why our recommendations were the way they were.
Right. And I think the committee has demonstrated its willingness to incur upfront costs when there is clinical data to support, clinical outcomes. I think, for example, going back quite a few years, we did move forward with getting insulin pens on the preferred drug list, even though it did incur a marked cost because there was significant pharmacoeconomic data to support utilization, improve adherence, better outcomes. We just don't have that data at this point, and it would be great if, I think if we get the data from the manufacturers or someone else who's doing research in the area to help support it. But without that data, the data that we have is the actual cost, and I think it's going to be a very significant cost implication to make the change that is being requested regarding Brixadi, particularly in light of the significant deficit Indiana Medicaid is currently experiencing. So, I think we want to be very data-driven. I think we're also very sympathetic to clinical outcomes if we can achieve it.
And we still, again, the PA process is there. Please give us your information. If you have somebody that has rationale for using one over the other, we do take that into account. We do review that. We do have utilizers of the product. So we do evaluate that. And if you have examples where you feel like a process was not followed, again, please escalate those, because we do review. I'm not going to say somebody doesn't ever make a mistake. Things do happen. Everybody's human. So we do review those, coach if we have those or that occurs, but please escalate them so that we can get something corrected in a group if that is happening.
And I throw in that proactively. So in other words, if you have a patient that's coming in that would meet some of the items that we talked about, just before they even get there, seek the PA, get it taken care of ahead of time. I realize that that's not always going to be the case, but don't wait on a denial then to submit a PA, submit it proactively.
And I think, the other thing that I'll just say is, as a committee, we have looked at this medication or this class of medications at every meeting, on cycle and off cycle. And so I would request that we continue to do that as a therapeutics committee. And then obviously this is also information that can be presented to the DUR board if there is something that, comes to light that perhaps needs to be acted upon quicker than what this committee meets. And so I will just say that again, as a committee and for Optum and the state, we do maintain our goal of reviewing this as actively and proactively as possible. So again, if there is information or cases or examples that would help us continue to form our opinion around this class of medications, again, please communicate that information to Optum and to the state. And then again, they can bring it to our attention as a committee as need be, so we can have all the information available. But with that, I will make a motion to accept the recommendations as presented by Optum.
Okay. So moved. Is there a second? Okay. So the motion has been moved and seconded to accept Optum's recommendation regarding the agents for the treatment of opioid use disorder or overdose. Is there any further discussion? It has to wait until public comments. We'll get to you. Okay. I'm hearing none. We could go ahead with the roll call.
Dr. Shaw,
Aye.
Dr. Krupp. I'm not sure I caught that. I'm sorry. Oh, thumbs up. Okay, we see the thumbs up. Perfect. Dr. Marshall,
Aye.
Mr. Musio, Dr. Dingendink,
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
All right, we have all ayes, so that motion will carry.
Okay. All right. New business. I don't think there's anything to vote on regarding new business. We'll move on to the public comment section.
So I would just ask for the public comment. We can have people provide public comment if they wish to, if they were registered for the first session, but I know you were, so that's why I'm just saying for the global group as a whole, like if you were registered, you're permitted to provide public comment in the second round as well. So I believe Dr. Meacham is first, so I will turn it over to him for public comment first.
I thank the committee for taking the time to look at these issues. They're extremely important. Having lost a son to this disease, I get it in a very personal way. Going back to your comments about insulin pens versus syringes. I trained at Harvard at the Joslin Center at a time where those new and emerging therapies were coming about. So I lived through that. I have a box of glass syringes and 21 gauge metal needles in my basement. And I look at those once in a while, remembering those days. History will repeat itself here with this class of drugs. The newer medication that's available in the form of Brixadi has many advantages for patients today. The volume of the injected fluid is so much smaller, much more comfortable, easy to take. Patients stay in care longer. We will prove that at some point. Someone will prove that. I don't say we in putting me in that box. We can't continue to work with those glass syringes and metal needles like we did with insulin for so long. We've got to move forward. We should not delay parity for these two medications. We have to have access to these things. The death rate from this disease is much higher, and it is taking a much younger population of humans than almost anything else out there. This committee has the ability to make these treatments accessible. And I beg that you would reconsider this. And with that, I'll rest.
Could I ask a question?
Yeah.
I can tell you from the Office of Medicaid Policy and Planning that we want to do this. We want to, and we hear you. And, from the emotional standpoint, but clinically we get you too. And we actually try to make it as accessible as possible through the PA. But ultimately we would love to take the PA away. We would. Have you made this kind of a pitch to the manufacturers of the long-acting injectables? Because it's great to have this venue and we want you to talk about this, but we cannot seem to get those manufacturers to budge, or it's budge in inches. And when you're talking about orders of magnitude in expense, and it's just, we can't seem to get that message that we hear and we feel, we can't seem to get that message through to them. And so I just would challenge you to also talk with them in the same way that you're talking with us, because we want to, and it wouldn't take a whole lot for us to get there. We just can't seem to get them there. And that's where I would say.
Yeah, I would not want to be in the position that you're in. Okay. Balancing the financial cost of a human life is a very, very difficult thing. I understand that. I do think we live in a time where we're going to have to move past some of that, though. because some of the downstream costs of human life are unmeasurable. I alluded to in my first 2-minute comment about when a patient comes in and receives an injection that's very uncomfortable for them, or when they receive an injection that causes a skin erosion or a side effect. Unlike a lot of disease states, they don't come back. They just disappear. It's just as easy for them to go to the gas station and buy $20 worth of fentanyl as it is to come back and endure that difficulty of getting through the process. And then to your point about the PA process is light years ahead of where it was even 2 years ago. I applaud the efforts of this group and others, for making that happen. But as I said earlier, we're sitting oftentimes facing a patient for the first time who made a very difficult decision to walk through the door, because it is so much easier to go to their dealer than it is to come to their doctor. Okay. And when we tell them that we have to wait to get something, even if it's a short period of time, what do you mean you have to wait? And I'm just giving you what I hear day in and day out. Okay. I think the whole concept of prior authorization in this disease state is somewhat arcane. Okay. It would be better to have the clinicians trained in treating this disease have free access to medications and then get the patient stabilized and look for another path forward. I don't know that we'll ever get there. I know that's
I think
utopian.
we will. I do. I think we will get there.
Yeah.
I think that everybody has to come to the table.
Yeah.
We hear you. And we, like you said, we've tried to make this as easy, doing things proactively on the PA side. So when you're bringing a patient in and you're anticipating an issue like that, submitting the information that you can prior to that visit, so that it's just a walk on out with your prescription and get it filled kind of thing, or an injection in your case in the office or whatever. Proactive is great, but everybody needs to come to the table, and we need to get somewhere on this. We can't seem to get there.
Yeah, and I'm not. Of course, I'd like to see the PA process streamlined or different or better, easier, but at the bare minimum, having parity, having access to all forms of therapy really ought to be on the table.
It has been. I mean,
extensively.
extensively.
It ought to be available, is what I
Yeah.
should say.
So I guess maybe this is an example, because this is how I think of it, and it is really hard. And I can tell you there are nights, like ethically, where I myself have sat up thinking but if you think of it in this way, I'm going to really oversimplify this because this is not how their budget is. But let's say the budget's $100. And let's say and all they have is 100, and one drug, like say Brixadi costs 100, which it doesn't. But it's the sake of example. And then I can only treat that one person versus the other 5 people I have that are also going to potentially die because I can't treat them. Or I can say, hey, give this injection, which is only $10,
Right.
and then I can treat the other 5 people that are also going to die. It's trying to balance that whole concept of while I agree, treating healthcare shouldn't be about a budget, but it is. We only have a certain number of dollars in the budget, and when it's gone, it's gone.
Yeah, no, I understand that. And what we're getting into now is the ethics of medical care and
100%.
the ethical principle of beneficence and how we distribute the treatments that we have.
Mhm.
I understand that in a very deep way. At the same time, when the patient is coming in for treatment, I'm not saying that everybody ought to go on an injectable. Far
Sure.
from it. Far from it. What I'm
Sure.
saying is that we have something better than the glass syringe today as an option for treatment. And when we give a 300 milligram dose of one product that comes in a 3 ml thick viscous liquid through a 19 gauge needle versus a 0.16 milliliter thin, easy to administer dose of medication, and we make a patient suffer through the first one before we can get to the second one, that doesn't make any clinical sense or any sense in any way, to be honest with you. We really need that parity piece. And then the next.
I don't want to interrupt that. In hearing you say what you said in that description, it sounds like you want parity, but actually, if you're going to give a patient a long-acting injectable, you're going to use Brixadi.
I would,
Okay, and that's important.
and I can
Yeah.
justify that.
No, I think actually I get the justification. I do.
Yeah. Yeah, and as a patient, listening to patients who have received both, they would prefer one over the other. Again, it's the glass syringe. I don't want to use the glass syringe anymore. I want to use the product that is more readily acceptable.
But in our current fiscal environment, if we can get to financial parity, we can get to coverage parity. I think that's the struggle. That's the sort of the bottom line, right?
Yeah.
We only have so many dollars, and so we have to make that tough decision. But at the end of the day, if we can get to financial parity, then we can get to coverage parity.
Yeah.
Which is what you're really asking.
Right, and we need more data for that, clearly. I think just having the number of patients. I beg your pardon?
Say, we just need more monies in some ways from the manufacturer. I mean, yes, the data helps for sure, but it also just helps if we have the money. We were talking about it earlier, the Jerry Maguire movie, and it's kind of fitting in this potential situation. I mean, if we get to financial parity and have that money, then it's at financial parity.
Yeah.
So that's why Mr. Ross was asking you if you'd had those conversations with the manufacturers, because if they can speed that process along and getting to financial parity, then we're at a place where we can do this right away.
I've had those conversations, just as I've had this one. And I really appreciate the opportunity to speak to the group today. And I do hope, I would, for the record, say that a year from now, we'll have this. I can't see that there's any other way that we can. And some of the comments that were made earlier about continuing 300 milligram injections, I take issue with that, medical issue with that. The American Society of Addiction Medicine has a position statement about finding lowest effective dose. Okay, treating patients, stabilizing them, and then finding lowest effective dose of maintenance medications. Putting someone on the same medicine month after month after month, or worse yet, putting them on a medication month after month after month that was initially brought to market as a loading dose is not in line with that. So these are all things that we, I think, need to take into consideration as we look at this. And I don't want to take any more of the group's time because I can see they're kind of waning a little bit, and I get that. But thank you very much. I wish we could go back to the
We appreciate you
equal
taking time.
playing.
Yeah.
Mhm.
Yes.
Thank
All right. Thank you.
Thank you.
Anybody else on the public comment list that wishes to speak?
Just as someone who has worked in other areas of medicine before I went to addiction medicine, I think it's important also that we, how do I say this? So the states that are around us, they have parity. They have, they don't have this, prior authorization God that you have to jump through to get patients' care. And so I'm not from here, and I understand the whole financial, obligation to the state to have the data and all the things. I guess I just, I don't understand how all these other states have been able to prove this data, but yet somehow Indiana has not. And we have such a high overdose and death rate here.
So a couple things. One is the other states haven't necessarily proven it. It's that a lot of the other states have legislation mandate that requires them all to be without PA and at parity. So then they allocate dollars, like they go through a legislative process where it's in law, and then they go to a financial group that figures out what the cost is going to be, and then they allocate additional budget for that. They could tell you way more about that than I could. But that's what actually a lot of the states have done.
Okay.
Is more around, it's more around that end than it is the other. And so
I don't know those the ones that don't have that, some of them could have been able to negotiate and get better deals. We don't know because,
yeah,
we
every
can't
state is
reveal and
unique
they
in
can't
what they're
reveal
able to
us.
negotiate.
Yeah. But Amanda's point is that we can't actually speak to the other states because it's a different thing for everyone. Again, we do not want to have PA. we would love to have parity and to be able to, dish this out. And we just cannot get some manufacturers to hear us and react in some way, even to some little significance. We can't seem to get that. So, but as it's been brought up, we look at this is an off-cycle review. This thing gets brought up usually on an off-cycle basis, twice a year. And so if we could just get them to play at least a little bit, that's all we're saying.
Okay.
Yeah.
So the data that shows
That
that the long-acting injectables have better patient outcomes.
Well,
than the
and
oral.
that's the thing is the data, we don't see that. The data that's out there. And we've asked the manufacturers for those data and they have actually provided it to us, and it's not very good data. And so we're not seeing and anecdotally, you're going to see those things. Absolutely. But in general, we are not able to see that right now. And we challenge the manufacturers. We'll continue to look for independent research. But right now, we're not seeing that as far as orals versus injectables, that it's there, that those data are there to support that.
I think just the difficulty in my own practice is that I have patients, like in my example, that unlike other disease processes they cannot manage, pills. And so as a medical provider that has a DEA license, I can't continue to prescribe, oral medications to someone that can't manage them, because their disease process is such
So
that
that is a very simple, speedy PA process. My patient is unable to manage the orals because PA approved. That quick. It's that quick. And if it
In
doesn't,
Medicaid.
But I have not had that experience though.
so again, we need to see those situations, because if what you're telling me is correct, someone is not doing their job correctly in Indiana Medicaid, and we will get that taken care of immediately. Just send us the examples,
Okay.
patient name and their Medicaid ID. That's all we need, and we can look at the claims data and get that fixed.
And not to put this individual on the spot, but we do have a committee member that does treat in addiction medicine. And so we did ask Dr. Negendig to provide her feedback on how the PA process has been and things. So I don't know, Dr. Negendig, if you have any feedback you'd like to also provide now, maybe around that, since you said overall the process seems to be working really well for you.
Yeah, I'll provide some feedback, and clearly, as not everyone knows, but I'm also addiction medicine board certified and very passionate about this cause. Understand a lot of the data, and so it's always a tough situation to be in, to manage both sides here. As far as the PA process goes for our Medicaid patients, I don't think we've had once where we haven't had a quick turnaround on that. So I'm not sure exactly. I hear people saying they're having trouble, and I don't doubt it, but I'm just also going to encourage, if you do, please go ahead and send those examples in, because we haven't had it. Again, with other insurance, we have. Our Medicaid population, we haven't. So again, please send those examples in so we can see those.
And that's the MHS. I'm sorry, I'm very illiterate with what y'all hear. I know there's all kinds. There's MDYs, there's MHS, there's all the things.
Yes, and you can send them all just directly to me, so you don't have to parse through that, and then I'll do the parsing and make sure it gets to the right individual, along with the state, since the state oversees the managed care.
Okay.
And we'll just make sure that we get the right people involved. So I don't want you to have to worry about, oh, this one is here, I need to contact this person. You can just contact me directly and I'll make sure we get it parsed to the right individual.
I have had good luck with Anthem HIP. I don't know if that's part of a different
Nope, that's
section.
us. Amy
Okay.
Berger on the phone will love to hear that. She will be excited about
Who?
that.
What? Who? Oh, okay.
Yeah, she's on.
Oh, okay. Yeah, I think that if I see Anthem HIP, because I try to let the patients know that there might be a few hiccups. I don't usually say that with the thing, whatever that one is. Okay.
Thank you.
You're
Thank
welcome.
you. Thanks, Dr. Negadank as well. Didn't mean to put you like right in the hot seat,
No,
but
I'm happy to speak. Thank you.
One of the things that has not been said today, we are simplifying, the PA process has been greatly simplified and it's much easier than it once was. But it still takes time. Okay, it still takes staff. It still takes time on the phone back and forth. And I can tell you this, 100% of the time, when I've had to do a peer-to-peer, the decision has gone favorably for the patient, okay? But to get to that point takes an enormous amount of time, okay? And in this treatment space where every minute and every dollar counts, okay, it's really challenging to have to jump through even the smallest hoops sometimes to achieve the end game that you want. So I just throw that out there. The time inside the office is not an irrelevant component of this. It's a huge part. You have staff that are trained to do PAs. They spend their whole day working on them, not just for this class of drugs, but others. And it's a considerable burden on the treatment side as well. So I want to put that out there. And again, my last comment is going to be about parity. I think parity is absolute must-have at this point in the process. When you look at 750 overdose deaths last year and over 2,500 emergency visits for drug-related issues, not having access to both medications equally is really a challenge. So I'll rest. I swear I won't come back up.
You're definitely welcome to come.
All right. Well, I have a lot invested in this disease state. So thank you for hearing me.
Thank you.
anyone else wishing to provide public comment that was registered earlier?
Well, I'll go ahead and add to the record that we appreciate the 3 people who wrote in regarding QLIPTA, although we
Oh.
were not able to comply or fulfill their request, but do appreciate when people write in.
All right, I think that then takes us to any other business at this point that the committee has.
I don't think so.
All right, Dr. Shaw, I will let you adjourn us for the
All
day.
I will go ahead and call to close the February 7th, 2025 meeting of the Therapeutics Committee to a close. So thank you everyone for attending.
Thank you. Have a great weekend, everybody. Appreciate your time.
Thank you all.